Everyone. So I'm going to go ahead and do a soft intro here as we give more time for our participants to join. And I see everyone saying hi here in the chat. Hi. I see somebody asking for slides for DKA and child respiratory. Actually, this topic we're doing right now is going to be labor, birth, and risk conditions. And then I see someone saying they're sleepy. Well, hopefully you can stay awake. Feel free to unmute yourself and participate so that you don't fall asleep. It's 4 a.m. in Kenya. Oh my goodness, you guys are really committed to your studying. I love that. I used to have to wake up at 3 to 4 a.m. and drive really far to go to my clinicals during nursing school. So it's rough. And I've also worked nights. Usually around 4 a.m. is when things get a little crazy in the hospital. All right, I'm going to go ahead and jump in here into our presentation. So welcome everyone. I'm really glad that you're here today. I just want to say thank you. I'm grateful for your presence. Today we're going to be talking about labor, birth, and risk conditions. And whether you're starting up or you're brushing up for the exam, whether you are learning some of this stuff for the first time or just brushing up on your information, I'm hoping that this webinar will give you confidence to feel good about taking the exam and to feel confident when you talk about these topics. So today we're going to break down some concepts that frequently show up on the NCLEX as well as in real life in OB practice. And we're going to start by reviewing some critical risk conditions that affect pregnancy, such as placenta previa, abruptio placentae, and then we're going to dive into some infections that can happen during pregnancy, like the TORCH group infections, which is toxoplasmosis, rubella, CMV, HSV, and GBS. These all carry really serious fetal implications. So it's important that we talk about them. And then from there, we're going to transition into labor and delivery mechanics, like the 4 Ps, like fetal positioning and Leopold's maneuvers. And we're also going to examine fetal monitoring and try to recognize patterns in fetal heart rates that can indicate distress or safety. And we're also going to walk through the 4 stages of labor, but actually today we're just talking about stage 1. And it involves the latent, active, and transition phase. On our next webinar next week, we're going to be talking about stage 2, 3, and 4. And of course, as usual, we're going to close out with some NCLEX style practice questions to sharpen your critical thinking. So I'm hoping by the end of the session, you will leave confident in identifying priority signs, choosing safe interventions, and applying your knowledge using NCLEX reasoning. So let's go ahead and jump in. And for those of you that already know me, you know that I'm Maria. I'm an RN. I've worked in various areas of healthcare, and I'm an NCLEX prep educator, and I'm happy to be here with you today so I can break down these topics. This is actually my topic that I'm most passionate about, which is maternal newborn health. My goal is to become a nurse midwife one day, so this is what I love the most. But I also talk about adult health. I teach different things as well. And then, like I said, we're gonna break down some topics today. I'm gonna go ahead and mute everyone here just to make sure that everyone can hear. And then I want to let you guys know the structure. As I go between slides, if you haven't been in my webinars before, as I go between slides, I will be coming back to the chat box to check on you guys. If you have any questions, if you have a comment, if you want to discuss a certain topic in more depth, or if you want me to go back to a slide, if you need a break, drop it all in the chat box, let me know, and we'll work it out for you. And I'm seeing everyone saying hi. So yeah, the webinar PowerPoint is uploaded on the Naxlex website, and you guys will be able to download a copy when you go back to previous webinars so that you can rewatch, to review, and then you can click on view slides, and it should take you to the slides that I'm using today. So if you're comfortable, let us know your name, say hi in the chat box, tell us where you're from, and what healthcare experience do you have? Have you been a CNA, an LPN, or LVN? Have you been a medical assistant? Have you been an EMT? Have you not worked in healthcare at all before? Have you already been an RN and maybe you're just transferring? Let us know. We want to hear and get to know each other. So the first topic we're going to talk about today is placenta previa. I don't know if you guys have heard that term before in your maternal newborn health studies, but placenta previa is a condition where the placenta actually implants itself low in the uterus. So the placenta can implant itself in many different places. It can be at the top of the uterus, it can be in the front, in the back, and that can actually affect how the pregnancy goes along. It can affect delivery of the baby. It can affect certain symptoms in the mom. It can affect how soon the mom can feel baby moving. So different positions for the placenta, but placenta previa is the most dangerous one. And it's basically where it covers the cervical opening. Now, the reason why this can become dangerous, especially during labor, is because the cervix needs to dilate for birth, right? We're going from 0 centimeters all the way to about 10 centimeters in order for baby to go through the passage. But if the placenta is in the way, this is going to put both mom and baby at a huge risk of bleeding. We know that the placenta is the main source of nutrients, of oxygen, of blood flow to baby. So anything happening to the placenta can be really, really dangerous for mom and baby. Now, there's three types of placenta previa. One of them is going to be complete. So the complete previa is going to be when it covers the entire cervix. We can have a partial previa, which is when only part of the cervix is covered. And we can have marginal previa, which is when the placenta is closed, but not necessarily covering the cervix. So it can be a little bit off to the side in the front or back, but not necessarily fully covering it. Now, this is pretty rare. It does occur only in 1 out of 200 pregnancies. But the hallmark sign of placenta previa is going to be painless, bright red vaginal bleeding. Now, those are huge NCLEX terms right there, painless and bright red vaginal bleeding during pregnancy. If you have painless, bright red vaginal bleeding during pregnancy, always think placenta previa. And this is usually going to take place in the second or third trimester, not really in the first. Now, this is an NCLEX favorite because it involves prioritization as well as safety precautions, especially avoiding anything that could potentially stimulate labor or cause bleeding, like vaginal exams. So, if you have a patient that's in their second trimester and they're coming in, they're having bright red vaginal bleeding that's painless, and they're concerned, would you do a cervical exam on them to check their dilation? Absolutely not. And the keywords here again are painless and bright red vaginal bleeding. Why? Because we need to assess and make sure that they don't have a placenta previa. Because if they do, and we're doing a vaginal exam, we could potentially cause more bleeding and damage to the placenta. So we don't want to do that. And I do have a mnemonic here called place, right? To think about the place where the placenta is. And it stands for painless bleeding, low implantation, avoid vaginal exams, cesarean likely, and expect monitoring. Now, the most important clinical clue in placenta previa, like I said to you guys, and the reason why I repeated it over and over, is bright red painless bleeding in a woman in her second or third trimester. And unlike abruptio placentae, the uterus here is going to be soft and non-tender. And we'll talk about abruptio placentae soon. But this one is going to be soft and non-tender. So if you do a palpation on the outside of the mom's belly, the uterus is going to feel soft to the touch and it's not going to be tender or painful. And the fetal heart rate is usually going to be reassuring unless, of course, the mom becomes hypovolemic from excessive bleeding. Now, this is going to be a classic do not do scenario, right? Never perform a vaginal exam when previa is suspected because it could trigger massive hemorrhaging in the mom, like I said before. And instead, the diagnosis of placenta previa is actually going to be confirmed with a transabdominal ultrasound. Now, if your patient does come in and they're having this bleeding, they're not having any pain, they're in their second or third trimester, you're not doing a vaginal exam, right? But you are going to be watching for signs of hypovolemia, right? Which would be tachycardia and hypotension combined. If the bleeding becomes significant, that could be a real danger. So I have another mnemonic for you here, and it's previa, and it's with each letter of the word that stands for painless bleeding, red blood, evaluated by ultrasound, vitals normal unless severe blood loss, internal exams no, and assess fetal well-being. I'm going to check in on you guys here. I see CNA for 3 years. Awesome. Just checking in the chat box here to see what you guys are saying. And if you have worked in healthcare before and you're becoming an RN, that's going to be so helpful to bring all that experience that you got. All right, going back here. So, if a client is diagnosed with placenta previa, they come in, they're having the symptoms, you call in ultrasound, they do an ultrasound, and it comes back, yes, they have placenta previa. Now, the management is going to depend on whether this person is bleeding and how far along in the pregnancy they are, right? Now, typically, if they are getting their regular prenatal care, they should know that they have placenta previa because during their scan, their physician is going to be able to tell when they look at their ultrasound scans. And one of the things that they tell you in the ultrasound scan is where the placenta is placed. And if they have placenta previa, the physician is definitely going to let them know and they're going to be cautious about it. They're going to know the precautions, they're going to be educated on that. But if they haven't had any prenatal care and they don't know that they have it, or maybe they haven't had a scan, whatever the reason may be, that they don't know, and now they come into the hospital, they do an ultrasound and find out they have placenta previa, of course, you need to be prepared on knowing how to manage this condition. Now, if there's no active bleeding and the pregnancy is pretty early on, we may manage this patient as an outpatient with activity restrictions. And these activity restrictions are going to look like no sexual activity and no exercise, right? And they're also going to need frequent follow ups. And the reason why is because we don't want any physical trauma to the cervix that could potentially injure the placenta and cause bleeding. Now, if bleeding is present or they're further along in their pregnancy, they will likely need to be hospitalized. And the nursing priorities for this are going to include monitoring their vital signs, of course, monitoring their bleeding, right? How much are they bleeding? Is it bright red? And we're also going to be monitoring their fetal heart tones. We need to make sure baby's okay. We're going to start them on IV fluids in order to maintain their healthy fluid status, and we're going to draw some labs. One of the first things we're going to do, of course, we're going to do a CBC, right? We want to see how they're doing, but we're also going to do a type and screen. What if they need a blood transfusion? And then potentially, if they are close to delivery and they are bleeding and we're in an emergency situation, we could potentially prepare for an emergency cesarean if the bleeding worsens. Now, these patients are also at increased risk for postpartum hemorrhage. For these patients, you are going to anticipate using uterotonic medications like Pitocin or oxytocin post delivery. Now, that's typically used anyways For most patients post delivery, they are administered a dose of Pitocin just to make sure that their uterus is contracting appropriately and that we are preventing postpartum hemorrhage. But it's especially going to be vital for these patients. And then I have some quick Q and A's for you here, just as like a little bit of a quick review on placenta previa. And I want you to think about the two main things about placenta previa, and it's going to be that painless, bright red vaginal bleeding and no vaginal exams. That can't be stressed enough. I want to remind you that the diagnosis is by ultrasound, and delivery is usually going to be a C-section for these patients, especially if the placenta is completely covering the cervix. And the most important interventions here are going to be early identification. We're going to monitor them conservatively, and we're going to educate the patient on their restrictions. This is going to be essential for their safety. So the questions we have here: what's the hallmark symptom of placenta previa? Again, painless, bright red vaginal bleeding. What diagnostic test confirms placenta previa? And that's going to be an ultrasound. Why are vaginal exams contraindicated? Because they can cause placental rupture and hemorrhaging. What delivery method is expected in complete previa? And that's going to be a cesarean section. And what is the fetal heart rate usually like in placenta previa? And it's going to be normal unless bleeding is severe and mom is suffering from hypovolemia. So let me know if you guys have any questions. Oh, I'm seeing some more comments here. I am a midwife. I love that. That's amazing. That's incredible. Very cool. Very cool. Okay. All right. Let's go ahead and move into the next portion of our presentation here if you guys don't have any questions. And that's going to be about abruptio placentae. And this is going to be one of the most serious obstetric emergencies that you would encounter, both in practice as well as on the NCLEX. And this condition actually takes place when the placenta detaches itself prematurely from the uterus, which can cut off oxygen and nutrient supply from the fetus, because we know that's the role of the placenta. And it can cause massive maternal bleeding. And this can happen typically after 20 weeks, and it's a very painful condition, which is a key difference from placenta previa, right? Placenta previa is painless. Abruptio placentae is definitely painful. Now, the abruptio placentae can happen in a concealed manner. The patient can have internal bleeding only, or it can happen in a revealed manner where they have visible vaginal bleeding. And your role as a nurse is going to be critical in recognizing this condition early, right? You're going to remember, you're going to know all the hallmark symptoms. You're going to stabilize the mom. You're going to monitor the fetus continuously. And you're going to prepare for emergency delivery if needed. So make sure that you're ready to identify risk factors, recognize clinical signs, and most importantly, implement life saving interventions fast. So we're going to go ahead and cover some of these topics here in the next few slides. So like I talked to you about before, when the placenta detaches early, now it can detach entirely or it can detach partially. But when it detaches from the uterus early, it can and will cut off oxygen and nutrient supply from baby, and it will cause bleeding inside of the uterus, depending on how big the detachment is, right? And this is definitely a life-threatening OB emergency for both mom and baby. And like I mentioned to you in the intro, there are two forms: there's concealed and revealed. And the terms are pretty straightforward, right? Concealed means you're not seeing any external bleeding, and the blood is actually pooling behind the placenta, kind of forming a hematoma in there. And then revealed is going to be when there is visible bleeding from the vagina. So we talked about placenta previa being painless. Unlike placenta previa, the abruption of the placenta is actually going to be really painful. Whereas placenta previa, we had a soft, non-tender uterus. With this one, we're going to have a firm, rigid uterus. And excuse me, this can very quickly lead to hypovolemic shock in the mom, as well as severe fetal distress. And some of the risk factors for this condition can include maternal hypertension. So, if mom has high blood pressure, they are definitely at risk for an abrupted placenta. Trauma, right? So, if they're in a car accident, they're experiencing violence at home, if they've been in any kind of trauma like a fall, something hit them in the belly, especially if they have an anteriorly placed placenta. So, if the placenta attached itself to the front wall of the uterus, they are more at risk for this condition. And then, of course, with smoking and cocaine use are also going to be two other risk factors for this condition. Now, I do have a mnemonic here, and it's abrupt, and it's A for abdominal pain, B for bleeding, R for rigid uterus, U for uterine tenderness, P for pressure elevated, and T for trouble for fetus. So, as I talked about, they're going to be opposites, right? One is painful, one is painless. One is the uterus is rigid and tender, one the uterus is soft and non-tender. So that should you should be able to kind of think about the difference between those two. Now, the classic sign of the placenta being abruptly detached from the uterus is going to be really sudden, sharp abdominal pain. And often there will be a firm board like uterus. Now, we also know that, like, when there's internal bleeding, like with peritonitis, or when somebody has, internal bleeding in the peritoneal cavity, their stomach is going to be rigid, right? It's going to be hard. And so this is going to be very similar. You're going to have a firm board like uterus when you palpate or touch it. And the bleeding is typically going to be dark red, whereas we have with placenta previas is going to be bright red bleeding, right? This one's going to be a dark red bleeding, and you can kind of understand why, because the placenta previa is coming directly from the cervix, so it's bright red. But with the abrupted placenta, since it has a longer way to make its way down from the uterus to the vaginal canal, the blood is going to be darker by that point. So, however, if you have a concealed separation of the placenta, of course, you're not going to see any external blood, right? Because it's going to be pooling behind the placenta and the uterus. Now, because of placental perfusion being compromised in this situation, the fetal oxygenation could drop. And this could definitely lead to non reassuring fetal heart tones like decelerations or bradycardia in the fetus. And the mom may actually show signs of hypovolemia, even if they're having minimal external bleeding. We don't know the extent of the damage inside, right? So we always need to ask mom about any recent trauma, any substance abuse, or if they're having high blood pressure. So definitely got to remember in our assessments and our interview, talking to them about, hey, what could have happened, right? And I have another mnemonic here for dark pain. For dark red bleeding, abdominal pain, rigid uterus, kick count decreased, pulse increased, anxious mom, impending shock, and non reassuring fetal heart rate. Now, the management is really going to depend on the severity of the abruption, right? And it's also going to depend on the status of mom and baby. So, if you have a mild case, they may just monitor, they may observe closely if the baby's doing good, baby's stable, fetal heart rate is good. And of course, if gestation is preterm, right, they're not ready for delivery. If it's just a mild case, we're just going to observe very closely, though. But if the mom is bleeding heavily or the baby is showing signs of distress, you're going to need to start some IV fluids. And I would also recommend that you're going to have blood products ready, right? Because your mom comes in, they're having dark red bleeding, they're having a rigid like uterus that's really tender. Maybe they're tachycardic. You don't know what the extent of the bleeding is inside. So right away, you're gonna start some IV fluids. You're gonna do labs. You're gonna type and cross to see what their blood type is, and you're gonna have blood products ready, right? You're gonna be expecting most likely to do a blood transfusion. You're going to position mom on her left side to improve blood flow to the uterus and the placenta. You're not going to perform any vaginal exams, of course. And that's kind of a similarity between the two of them. No vaginal exams. And then, of course, you're going to monitor for signs of shock. You're going to assess the fetal heart rate, and you're going to prepare for a stat cesarean. Now, again, we're also avoiding vaginal exams here. And the reason why is because we want to prevent further separation, right? And then, in addition to that, there's another factor that we don't talk a lot about, and that's going to be emotional support. Now, of course, our physiological needs of the mom come first. However, we also want to provide emotional support because obstetric emergencies can be really, really scary for mom. And I do have some questions and answers for you here, like what's the hallmark sign of abruptio placentae? And that's going to be sudden abdominal pain with a rigid uterus. We don't like anything sudden, right? And then, of course, how's the bleeding typically described? And in this one, it's going to be dark red, and sometimes it may be concealed. So if you have a mom coming in her second or third trimester, she's after 20 weeks, she's having sudden pain, she's complaining, my abdomen just started hurting really bad. It's like an 8 out of 10. They're kind of bending over with the pain. You palpate their uterus, and it's super firm and rigid, but you're not seeing any bleeding. You're still going to go ahead and suspect this. You're not going to do a vaginal exam. And you're going to go ahead, of course, and get that mom those life-saving interventions right away and notify the physician. Now, what's the priority position for this? It's going to be left lateral. That's always going to be a life-saving position for moms in gestation. What fetal heart rate pattern may appear? You may see late decels, or you may see bradycardia. And what's the delivery plan in most moderate to severe cases? And unfortunately, it is going to be an emergency cesarean section for this one. So remember, painful bleeding, abruption, painless bleeding, previa. And then, of course, you're going to want to act fast for these patients, right? So let me jump back here into our chat and see if you guys have any questions for me. I don't see any questions. Let's go ahead and jump into our next topic. We're going to talk about torch infections. And feel free to drop any questions if you have any. I'm happy to explain stuff in detail for you if you don't understand a concept, or even if you have some side questions about it. So this section is going to focus on a group of infections known collectively as torch. These are going to seriously impact fetal development if they are transmitted during pregnancy. And these are some of the common things that you hear as far as precautions go for pregnant moms, right? They're usually going to trace back to these infections. Some of these infections can be silent, which is really scary, but they can lead to devastating consequences for baby, such as congenital blindness, deafness, heart defects, neurological damage, or even fetal demise, which is the absolute worst outcome. Now, the acronym TORCH is going to help you remember the most important infections, and those are going to involve toxoplasmosis, which can be which the mom can catch from touching raw meat or from touching cat feces. And the O is going to stand for other, which is includes syphilis, varicella, which is also known as chickenpox, the parvovirus B19, and you may see these grouped separately. Now, the R is going to stand for rubella, which is a vaccine preventable infection. We actually talked about rubella in our last presentation. We're going to talk a little bit more about it today. Actually, we talked about rubella titer, but we're going to talk about actual rubella today. And then we also have CMV, which is the cytomegalovirus, and this is actually the most common one. And then we have HSV, which is the herpes simplex virus. And this one is especially dangerous if the mom has active lesions during delivery. And then this is also going to include a group B strep, which is also known as GBS. So when mom comes in to delivery, we're always going to ask if they have their GBS test done. Are they GBS positive or negative? This is group B streptococcus. It's not officially a part of the torch infections officially, but it is a major tested topic on the NCLEX. It is a perinatal infection. It's usually screened around 36 to 37 weeks. And the reason why we do it is because we want to prevent neonatal sepsis. So, moms that are GBS positive are going to have antibiotics. And we'll talk a little bit more about that. Now, each of these infections has really unique transmission risks, symptoms, and interventions. But the overall theme is going to be early detection, as usual, education. We need to educate the mom on how to prevent these infections and protecting the fetus, right? So let's go ahead and break down one by one. Let's start with toxoplasmosis. This is going to be one of the most dangerous torch infections because of how common and silent it is. Think a mom is pregnant, she has a kitty cat in the home, she's just doing her weekly cleaning of the litter box. And many people actually carry this parasite with no symptoms. So they can be carriers but not know that they have it. But it actually becomes really dangerous during pregnancy, especially in the first trimester, right? We know that in the first trimester, we are at risk for a lot of different things. So, transmission is going to happen when a woman comes into contact with the oocysts, which are found in cat feces, or if they consume undercooked or raw meat that contains the cysts, which is another reason why we tell moms they can't have sushi. Now, gardening without gloves and or eating unwashed fruits and veggies are also potential risks of this. So there's a lot of risks when it comes to moms and what they're eating throughout their pregnancy, especially in the first trimester. Now, if the mom does catch toxoplasmosis and passes it to the fetus, it can lead to a triad of congenital issues. And these are going to be chorioretinitis, which is something that leads to blindness in the fetus, hydrocephalus, which is, edema in the brain, and it can cause increased intracranial pressure. Also, intracranial calcifications. And you might see these complications listed on NCLEX style questions. And then there's going to be other outcomes too, which can include miscarriage, seizures, and they can include a baby being born with severe developmental delays. Now, there's no vaccine for toxoplasmosis, unfortunately, so prevention is going to be key here. We're going to emphasize to the mom to have really strict hygiene when it comes to their food, to avoid cat litter at all costs, and to handle their food properly, right? To make sure they're washing everything really well. Maybe they're wearing gloves if they're handling raw meat. And we're also going to educate our clients not to adopt new cats while they're pregnant, right? Maybe they think it's a good time, like, hey, I'm going to go out and get a new companion. Maybe they'll grow up with the baby. It's a nice idea in theory, but not a good idea when it comes to health. And we're going to go ahead and have mom delegate litter duties to other family members if possible, if they already have a cat. So we have a mnemonic here, don't touch the cat. And it's going to be for touch cat, which is toxoplasmosis, only eat cooked meat, use gloves for gardening, clean fruits and veggies, hand hygiene always, cat litter avoided, avoid raw meat, and it's transmitted via feces. Do you guys have any questions about toxoplasmosis? If not, I'm going to move forward to rubella here. Hope I'm not boring you guys. Let me know if you have any questions. These are some extensive topics, so we're going to get through it one by one. And I'm just trying not to read off the slide and just kind of give you some of the main points here that you guys need to know. But again, download the slides later so you guys can review on your own time. Now, rubella is a part of the torch group because it does have really severe congenital defects, and it can also cause a lot of problems if contracted, especially in the first trimester. So the virus is actually going to spread through respiratory droplets. So we're going to have droplet precautions, right? If mom wears a surgical mask, they should, in theory, be safe. And of course, if they avoid exposure to anybody who is sick or does, or has been exposed as well. And this virus, anybody who has been exposed to it or is sick with it, if mom is around them, not wearing a mask, not doing hand hygiene, they are being put at high risk of contracting it. And some of the fetal effects for rubella syndrome are going to be referenced on the NCLEX. So if you use the CHD mnemonic, that will help you. And that stands for cataracts, heart defects, like a PDA, and deafness. And you may also see microcephaly or developmental delays, just like in toxoplasmosis. Now, the key here for pregnant moms is going to be screening early, right? We're going to do a rubella titer in the beginning of their prenatal labs. All pregnant clients are going to get that done, usually on their first prenatal visit. If they're non immune, we're going to advise them to really avoid exposure and be really careful because they can't receive a rubella vaccine during pregnancy because it's a live vaccine. So, we're going to recommend prevention during pregnancy and after pregnancy to get the vaccine. Now, as nurses, we need to reinforce hand hygiene, wearing a mask, avoiding crowds, especially if there's any unknown outbreaks, and the importance of, if they are planning a pregnancy, to get vaccinated before conception. Now, talking about CMV, cytomegalovirus, this is going to be another common congenital infection. In fact, this is going to be the most common one. It does happen worldwide. It is often overlooked because most maternal infections are going to be asymptomatic or they're going to mimic just a cold. Now, the virus does spread through saliva and urine, which makes toddlers in daycare a major transmission route for pregnant people. So, if mom has another little kid, they're 2 or 3 years old, they are in daycare, they're exposed to lots of different stuff there, they come home, they're having cold symptoms. Now, mom has potentially been exposed. And there's no vaccine for CMV, so prevention is really going to rely on meticulous hand hygiene, hand washing, especially after diaper changes, and avoiding sharing food or kissing toddlers on the lips because they could be affected by this. And some of the effects on the fetus may include hearing loss, which is the most common one, microcephaly, seizures, liver enlargement, which is also known as hepatosplenomegaly, and a blueberry muffin rash, which is petechiae from thrombocytopenia. Now, the NCLEX will test CMV in the context of a pregnant daycare worker potentially, or a client that's exposed to young children's bodily fluids, like if you're a pediatric nurse. CMV can lead to lifelong complications for the baby, including developmental delays, which is a very common complication for all these conditions. And as nurses, we do need to teach prevention. That's going to be the most important thing, especially for those in childcare roles, whether they're moms, nurses, or early development teachers, babysitters, daycare workers, anything like that. Now, jumping into HSV here, this is going to be a lifelong viral infection that can cause devastating effects on baby, especially if transmitted during delivery. HSV1 type or type 1 is going to be an oral type, and HSV2 is going to typically be a genital type, but both can actually be transmitted during vaginal birth. And the biggest concern here is actually when a mom contracts primary HSV during pregnancy, especially in the third trimester. So moms will be tested for this. And without the mom having maternal antibodies, or without baby having maternal antibodies, the baby has no protection from HSV. So this is really scary. And neonatal herpes can actually present as lesions on the skin, the eyes, and the mouth. It can have involvement of the CNS, so central nervous system. We're going to have potential encephalitis and seizures. And there could be some disseminated systemic infections too. So the key NCLEX point here is going to be if there are any active lesions and if they're present at the onset of labor, we need to go ahead and do a cesarean birth instead in order to prevent transmission. Now, if mom has been exposed or mom is infected, we can give them prophylactic acyclovir or valacyclovir around 36 weeks in order to reduce viral shedding. And we're also going to counsel our clients on abstaining from sexual contact, especially during outbreaks, especially if they have it or if their partner has it. And we're also going to teach them about safe hygiene practices if we're known that, either them or their client or their partner may have it. So a scary, scary complication here. But again, this client would definitely need a cesarean delivery. Now, let's talk about GBS. This is a really commonly tested condition in pregnancy. It's going to be a naturally occurring bacteria, actually, that's found in the GI tract, as well as in the genital tract of about a quarter of women. So, about 25% of women will have this naturally occurring. It's harmless, it doesn't do anything throughout their life, but it can cause life threatening complications and infections in newborn babies, especially during labor and delivery where transmission is the highest, right? So we're going to go ahead and screen moms between 35 to 37 weeks using a vaginal rectal swab. So when they have an appointment during that time, we're going to go ahead and, the OB, the physician, the NP, they're going to go ahead and use a swab. They're going to swab the vagina and the rectum, and then they're going to send it out for testing. And if it's positive, the client does need to receive IV antibiotics during labor in order to prevent transmission to the baby. So that's actually part of our assessment when mom comes in to the hospital. They're in labor, they're about to give birth, and we're going to ask them if they are GBS positive, and we are going to go ahead and administer antibiotics during labor. Now, if mom is scheduled for a cesarean birth and the membranes are intact, then antibiotics are not needed. So, water hasn't broken, mom's getting a scheduled C section. We don't need to give her antibiotics because the baby at this point is not being exposed to any vaginal flora. And infants that are exposed to GBS without prophylactic antibiotics are at risk for early onset sepsis, pneumonia, meningitis, and potential death. And for clients that are allergic to penicillin, we are going to use clindamycin or vancomycin, of course, depending on their allergies or what their sensitivities may be. Now, it's important for the NCLEX for you to know the timing, the risks, and the correct interventions for these conditions. So, if a question is asking you what to do for a GBS positive mom in active labor, the answer is always going to be to give IV antibiotics to protect baby. And I have some questions and answers here for you. Like what food should be avoided to prevent toxoplasmosis in pregnancy? And that's going to be undercooked meat and unwashed produce. And of course, we don't want mom touching cat litter. Now, why is rubella dangerous in pregnancy? And that's because it can cause congenital rubella syndrome, which leads to deafness, heart defects, and cataracts in baby. Can the rubella vaccine be given during pregnancy? And that is no, because it is a live vaccine. So, mom is going to work on prevention, hand hygiene, not being exposed, and we're going to go ahead and give the MMR vaccine postpartum. What teaching is essential for a pregnant client with CMV, which is a cytomegalovirus? And that's going to be to practice really good hand hygiene and to avoid transmission. And remember our fact about toddlers in daycare. When is the herpes simplex virus most dangerous to the baby? And that's going to be during vaginal delivery if the mom has active lesions. So we're going to go ahead and opt for a cesarean instead. What is the priority if a mom has active HSV lesions at term? And that's going to be C-section, like I said. When is GBS screening performed? And that's going to be between 35 to 37 weeks gestation. And what is the first line antibiotic for GBS in labor? That's going to be IV penicillin. And if a mom tests GBS positive but is having a scheduled C section with intact membranes, should she get antibiotics? And no, because there's no risk of vaginal exposure at that point. And then what is the mnemonic for remembering GBS management? And that's going to be GBS, give baby safety, which means IV antibiotics in labor. And we are going to do NCLEX style questions. So these are just short Q&As just to kind of cover what questions you may have at the end of each section. But we are going to work through some NCLEX style practice together. Let me see if you have any questions here. No questions. All right. I'm going to go ahead and jump into multiple gestation here, which means a pregnancy with 2 or more fetuses. We have identical twins that are monozygotic. They come from one fertilized egg that splits. And then we have fraternal twins, which is dizygotic, which come from 2 separate eggs that are fertilized by 2 different sperm. And pregnancies with multiple gestation are going to have a lot higher risks for complications like preterm labor, preeclampsia, anemia, and even gestational diabetes. And for the fetuses, there is an increased risk of growth restriction, of course, because they don't have as much room to grow in there because they're sharing the space. There's going to be a risk of low birth weight and twin to twin transfusion syndrome, especially in monochorionic twins. And there's also going to be a risk of NICU admission. Now, as nurses, we have to ensure that these clients receive specialized, frequent prenatal care, as well as education in order to manage the risks. So we want to go ahead and focus on prevention, right? Now, a key clue to multiple gestation is going to be a larger than expected uterus. So we're seeing mom, she's at, maybe 16 weeks along, but her belly's a lot bigger than it should be already. So you may hear this as being described as measuring ahead of the dates, right? So that's going to be a big clue if this mom hasn't had an ultrasound yet. We don't know if she's having twins or multiples. That would definitely be one of the clues. Now, another clue is going to be higher levels of the HCG hormone and AFP. And this is going to be typical and may initially suggest a molar pregnancy or a neural tube defect sometimes, but it can also suggest multiples. But it's not going to really be confirmed until we have an ultrasound. So if we have high HCG levels, high AFPs, and then we're like, we're thinking her belly's kind of extra big for where she's at, but we're going to go ahead and confirm with ultrasound if she is having multiples. Now, if we're doing a physical assessment, the provider might detect multiple heartbeats with a Doppler, or they may even palpate several fetal parts, right? And, in the end here, the ultrasound is going to be the definitive diagnosis, not any of the other signs. So, but these patients are going to experience a lot more intense pregnancy symptoms early on because they're going to have really elevated hormone levels. So, if they're having extra nausea and extra fatigue and extra hormone like fluctuations and mood changes, we're going to think, putting these things together may sound like they're having multiples. And care for multiple gestation is going to be all about surveillance and support. These patients need to be monitored really closely for preeclampsia, for anemia, as well as for GDM, gestational diabetes. And these are going to be really common complications with multiples. We're going to have this mom have pay much closer attention to their nutrition needs because their nutrition needs are going to be a lot higher since they're sustaining more than one fetus, especially when it comes to protein and iron. And they may need supplementation of different nutrients depending on their individual case. So we might need a dietitian referral. But we're also going to monitor for signs of preterm labor, and we're going to educate our patient on that as well. This can be really common in twin or higher order pregnancies. So a lot of times, moms that are carrying multiples, they will deliver a lot earlier than their due date. We're going to teach them to report pelvic pressure, cramping, vaginal discharge, anything that may indicate that there is preterm labor going on. We are going to go ahead and educate our clients on that. So if you get a question on the NCLEX that asks you have a mom with a triplet pregnancy, what is going to be the priority for education? And you're going to go ahead and educate them on preterm, the signs of preterm labor. And then, of course, you're going to think about if you have any answer options too about educating them on gestational diabetes, hypertension, preeclampsia, any of those other complications that are common with multiples. Now, delivery planning is going to be essential for moms that are carrying multiples because if both twins are head down, vaginal delivery may be possible. But if not, they may require C section, especially if babies have a different presentation or if they are experiencing fetal distress. Now, some questions and answers that you may have about multiples. What is a key physical finding suggesting multiple gestation? And that may be a fundal height greater than the gestational age. So, if you guys were present for the webinar where we talked about measuring fundal height, that would be around 20 weeks. We measure fundal height, and usually it's going to equal or be approximately within 2 weeks of their gestational age after 20 weeks. So if it's measuring a lot higher, then we have a suspicion that they may be having multiples. But usually by that time, they'll have had an ultrasound anyways, and sometimes a twin is hiding in there, but for the most part, it should be confirmed by that point. Now, what lab value is typically going to be elevated in multiple gestation? And like we talked about, it's going to be the HCG hormone and AFPs. And what are some early symptoms that are more intense in multiple pregnancies? That's going to be nausea and vomiting. Moms of twins tend to have a lot higher nausea and vomiting because of the higher HCG levels. And what complication is going to be common in multiple gestation before 37 weeks? And that's going to be preterm labor. So usually babies are already big in there. There's no more room. Moms are going to end up delivering a lot earlier. What's the priority assessment for a patient with multiple gestation and uterine contractions at 30 weeks? And that's going to be monitor them for signs of preterm labor as well as cervical changes. Let me check on you guys here. I don't see any questions so far, so I'm going to go ahead and jump into the process of labor. Now, I'll introduce you to the 4Ps. The 4Ps are going to be the cornerstone of labor and delivery assessment. Think of them as like the interacting forces that are going to help or hinder the birth process. So, I don't know if you ever heard of the 4Ps before, but so usually when labor is not progressing, we're going to assess each of the Ps in order to identify like what's the barrier, right, to the labor progressing right now. So for NCLEX understanding, I want you to know how each factor is going to influence labor outcomes as well as interventions and what interventions are going to be critical. So the 4 Ps are going to be powers, passageway, passenger, and psyche. And those words are pretty straightforward, right? Powers are going to be the powers of the uterus, right? How strong are the contractions and the pushing? The passageway is literally going to be the passageway for the fetus, which is the pelvis and the birth canal. The passenger is going to be the fetus, and then the placenta is going to follow. Of course, it has to be delivered after the baby. And then the psyche is going to be the maternal emotional state and mental readiness. Now let's talk about the powers here. Like we said, it refers to the force that is going to propel the fetus through the birth canal. And uterine contractions are going to be involuntary, right? The mom is not causing them, they're just happening on their own because they're doing the work of dilating and thinning the cervix. So as labor progresses, maternal pushing is going to become really critical as you get closer to pushing time and it's time for baby to come out. Mom is going to need to push, right? And this is usually going to happen around the second stage. Now, coaching the mom on proper bearing down during contractions can actually improve the efficiency of the powers, and it can shorten the second stage too. Now, this isn't the case for everyone. Of course, you're going to ethically, provide this coaching to the mom. Does she want to be coached on pushing and bearing down, or does she not? If mom has an epidural, she's going to need to be coached on the pushing, right? Now, if she's like an experienced mom and she's more on the natural side and she's like, I don't want you to coach me on my pushing, I just want to do it on my own, then we respect that as well. But coaching can help because we're down there, we're able to see what's going on. And usually the physician is going to be doing this part, right? But the nurse can help too. But this is going to be really helpful. Now, if on NCLEX, if you're seeing a question about labor slowing down, we are going to be assessing the contractions first, right? This is part of the first P, the powers. Are the contractions strong enough? Are they frequent enough? And if not, then we may need augmentation, right? We may need Pitocin. We may need some form of labor augmentation at this point. But again, it's going to depend on a lot of different factors. Now, the second P is going to be the passageway, which is the pelvis and the birth canal. This is going to include both the bones and the soft tissues that the baby has to navigate through. We know that the gynecoid pelvis shape is going to be round and it's going to offer the most favorable condition for vaginal birth. And we talked about this on one of our previous webinars. So if you didn't see it, go back to the previous webinars, watch it, and download the PowerPoint so you can see what we're talking about here. There's different shapes and sizes of the pelvis. Some are favorable, some are not for vaginal delivery. Now, the most favorable is going to be the gyconoid shape. And as labor progresses, the cervix is going to dilate, right? It's going to open up and it's also going to efface. You're going to hear those two terms, dilation and effacement. Dilation is how much the cervix opens. Effacement is going to be how much the tissue around the cervix thins, right? It's going to be like literally thinning like this. And effacement is going to precede dilation. It's usually going to happen first in first time moms. So nurses should assess these changes via sterile vaginal exams. Now, of course, the only time we're not going to do a vaginal exam is if we're suspecting abruption of the placenta or placenta previa. And obstructions in the passageway, like a narrow pelvis, a full bladder, or a swollen cervix, can prolong labor and they can lead to interventions like C-section. Now, the third P is going to be the passenger, right? Which is the fetus and the placenta coming after. But this is going to be mostly about the fetus, and we're going to assess the fetus size, the presentation, the position, and whether the fetus is aligned properly with the pelvis, because the fetus presentation can actually kind of predict how labor is going to go. It's going to let you know if it's going to be an easier delivery or a more difficult delivery. So we want the baby to be cephalic, which means their head first, right? Their head is facing down. And then if we have breech or transverse presentations, breech with the head being up and the feet coming out first, or transverse when the baby is across the uterus, these are going to require a cesarean delivery. And the fetal position is going to be described using abbreviations like LOA, which stand for left occiput anterior. This is going to be the most common and the most favorable one for delivery. As you can see, it's the top right one, and it's when the fetal head is kind of facing towards the forehead, is kind of facing more towards the back, and the posterior part of the head is more angled towards the front of the pelvis. Now, in exams, if labor is prolonged or painful, like if mom is having a back labor, we're going to suspect that the fetus is in a malposition, like, for example, OP, which is occiput posterior. And that's going to be when the back of the baby's head is pushing up against the mother's lumbar. So it's going to be a lot more painful for mom and it's going to lead to a longer labor. Now, when it comes to psyche, mom's emotional readiness, never underestimate the power of mindset during labor. Mindset is going to have a huge effect on labor and delivery, because high anxiety can actually lead to mom tensing all her muscles, and also it's going to interfere with the efficiency of the uterus. So we need to educate the mom. We need to prepare her in order to reduce fear. There may be a lot of fear associated, especially as labor is progressing, pain is increasing. Anxiety is going to be a huge part of that. So as nurses, we're going to play a really big role in this P, the psyche, right? We're going to encourage deep breathing, massage, maybe water therapy, and we're going to go ahead and give continuous support to mom as well as to their support person too. Now, for NCLEX, remember, emotional distress can stall labor. So if you see a question about that and you're not seeing any reasons why physically the labor is stalled, the solution may not be medical. It may be psychological, right? You may need some support. And I'm going to read some questions and answers here for you, like what is the primary power that drives cervical dilation? And that's going to be uterine contractions. What pelvic shape is the most favorable for vaginal birth? That's going to be the gynecoid pelvis. And what fetal position is most optimal for delivery? And that's going to be LOA, the left occiput anterior. What are signs of effective labor contractions? And that's going to be strong, regular contractions causing dilation and effacement. So we want to see contractions. They're strong, they're close together, they're regular, they're becoming closer together, and they are causing cervical changes. We need to see cervical changes to see that it's true labor. And what maternal factor can negatively affect labor progress? And that's going to be anxiety and fear. So the last P, which is psyche. I hope I'm covering everything here. Let me know if you guys need me to answer any questions. I see, how is contraction monitored or counted from the start of a contraction to when? Yeah, so a contraction is we're going to monitor them on a little like machine. We're going to put um, these things on the mom's belly. We're going to strap them in. They have wired ones, they have wireless ones, and then it's going to print out a paper that's going to show us a comparison between baby's heart rate and contraction. And the contraction is going to be, we're going to measure them, and they're going to be they're going to kind of move through depending on what stage of labor mom is in. So let me see if I can show you guys a picture. So I'm going to show you guys a little visual here. So when it comes to contractions, you're going to time them. The length and duration of the contraction is going to be from the beginning to the end of each individual contraction, right? And then you're also going to measure the frequency or the interval, and that's going to be from the beginning of one contraction to the beginning of the next contraction. So that's where they're going to say, like, oh, it's happening every 2 minutes, it's happening every 1 minute. But it's going to be, oh, the contraction is 1 minute long, but it's happening every 3 minutes. So that's how it's going to be measured. I hope that helps. And I'm going to go ahead and move forward here into our next section, which is mechanisms of labor. And if you want and have any more questions and want me to explain anything else, please drop it in the chat box. I will check back in on you, and I'll be more than happy to talk about it. Now, think of these steps of labor like a kind of a choreographed dance, right? Each movement, mom and baby, are going to help the baby to align with the pelvis and to pass through the canal safely. And these mechanisms are going to occur primarily in the second stage of labor, right? And if there's any delay or abnormality at any point, this may result in the labor being prolonged, or it may result in the labor needing assistance, like forceps, vacuum, or cesarean. Now, for the NCLEX, I want you to know what each of these movements mean and when they happen. And this is often going to be tested in fetal positioning or station questions. So we have engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. So that's what the test, the each of the steps is going to look like here as the baby choreographs this dance of preparing to come out of the vaginal canal. So let's go ahead and walk through each of these steps. The first one is engagement, and that's going to mark when the fetal head is locked in at the pelvic brim. Once the fetal head, you may hear that, right? You may hear, oh, okay, he's head first now. Is the baby engaged, right? So once the baby is engaged, the descent is going to continue because of the contractions and maternal pushing. Now, after that, after the baby is engaged and the descent begins, right? Descent as in baby is moving downward towards the pelvis or through the pelvis, I mean. Flexion is going to be the next one, and that's going to be reducing the presenting diameter of the head. This is really important. Um, the baby is going to go ahead and kind of tuck their chin towards their chest in order to make the diameter less wide as they're going through, right? So they're going out, if baby's coming out like this, that's going to be a lot more on the cervix than if the baby tucks the chin in, right? And then we have internal rotation, which is going to be when the baby is turning to fit the anatomy of the pelvis. So baby's going to tuck the chin and kind of start to turn. The next one's going to be extension, which is going to allow the head to emerge underneath the pubic arch. So the head is going to go ahead and expand to pass the pubic bone. And then after that, the external rotation is going to realign the head with the shoulders. And in expulsion, the baby is going to be delivered. So if a baby fails to flex, rotate, or descend properly, the labor progress may stall. So you're going to think, it's baby's kind of stuck in there, right? It's not progressing. You're going to think there's a malposition going on, or potentially there could be a cephalopelvic disproportion. So maybe baby's head is too big for the pelvis. Now, I want to talk to you about Leopold's maneuvers. Leopold's maneuvers is going to be a maneuver that's going to help to determine which part of the baby is presenting and how it's positioned in the uterus. And this is going to be super important when planning a delivery or monitoring fetal well being. This is something that midwives are usually really good at doing. It's a really non invasive, safe assessment. And it is a skill that you'll use during your OB clinicals or during your assessments before any labor interventions. So for the NCLEX, they might describe a scenario and they might ask what you would expect to palpate or what that finding would suggest. And this four-step abdominal palpation is going to assess the fetal lie, the presentation, the position, and the engagement. And we're usually going to perform it between 24 to 36 weeks or in early labor. Now there's four steps. We're going to break it down. Step one is going to help us to identify what is in the fundus, right? We know the fundus is the top of the uterus. And that's going to let us know if it's the head or if it's the buttocks, right? If we're going to touch the fundus, palpate the upper abdomen to find the fetal part. If it's hard and round, we know it's the head. If it's soft, we know it's the buttocks. Step two is going to be to locate the fetal back. We're going to palpate and see if we're feeling the back or the limbs, right? So we're going to see, is it smooth and firm? Okay, that's definitely the back. Or is it like little small movements? Then that's likely going to be the arms and the legs. For step three, we're going to check what's presenting in the pelvis. So we're going to grasp right above the pubic symphysis to assess the presenting part. If the head is present but not engaged, it may be palatable. And step four is going to determine how far the baby is in the pelvis, right? Engagement is going to equal a fixed part, but no movement. So we're going to go ahead and feel around in the belly for that. And that's kind of what it looks like in that diagram. And it's a nice, non-invasive assessment, like I said. And this assessment is going to help to plan delivery as well as to monitor the descent of the baby. So it's still important to know that. Now we have some questions here, like what does fetal engagement mean, right? What is that? Well, that's when the widest part of the fetal head has reached the ischial spines. And what movement is going to allow the head to emerge underneath the pubic bone? That's going to be extension. We talked about those different movements, right? The fetal dance that the fetus does as they're coming out. What does step two of the opposed maneuver assess? And that's going to be the fetal back versus the limbs, right? We're going to feel something kind of smooth and firm. It's the back versus little tiny movements is going to be the limbs. And if the presenting part is palatable, what does that even mean, right? That's such a weird word. Well, it means that it's not yet engaged and it can still move upward. And which fetal position is associated with the painful back labor, right? When baby's head is pushing up against the lumbar, and that's going to be occiput posterior or OP. Now let's talk a little bit about fetal monitoring. Fetal monitoring is going to help us to ensure that baby is tolerating labor. So we are going to go ahead and strap mom's belly up with some probes. And it's also going to tell us about oxygenation of the baby. It's going to tell us how stressed the baby is, as well as like what's their general well being, right? Because we're going to watch the patterns in their fetal heart rate. And we're going to use two main external methods, or two main methods. It's going to be external and internal. External is going to be the most common one. It's going to be non-invasive, and it's going to be those little straps that you see in the picture. And then the internal is going to be needed when we need some more closer data, like we need something a lot more precise, or even if we are trying to move around the external and it's not reliable, right? It's not really picking up consistently. We might need to go with an internal option that is a little bit more invasive. And it does have some higher risks, but again, usually used in labor that's already higher risk. And the NCLEX may ask you questions about decelerations, variability, or what to do when patterns are going bad. So let's go ahead and break it down a little bit because this is kind of an extensive topic. And I'm going to try to get through it real quick so we can go ahead and get through our PowerPoint and get to our questions. So external monitoring is going to be placed on mom's belly. There's going to be these little stretchy belts that we're going to kind of Velcro on, and we're going to move the probes around to find, one at the top and one at the bottom. We're going to detect fetal movement as well as the contractions. One of them is going to detect the heartbeat, and it's going to be via Doppler ultrasound. And the other one is going to detect the tension from the contractions, which is called a tocotransducer. Now, this kind of monitoring is painless, it's easy, and it's safe. But it can be less accurate in patients who have more fatty tissue around the belly, or it can be less accurate if mom is moving around a lot, or even if mom has twins, or if baby is really active and moving around a lot. So there's lots of different variations to this. And sometimes if you have an anteriorly placed placenta, it may be hard to find the baby's heartbeat. Sometimes mom may want a more natural birth plan and may not want to be strapped down with the monitoring straps. So we might give them the option of monitoring them as long as they're a low risk delivery. Might give them the option of like, okay, go move around and then come back and we'll monitor you like, once every hour, depending on what stage of labor they're in. Now, this is usually going to be the standard in most hospital labors, but if the readings are unclear or if any complications come up, then we will move to internal monitoring. And internal monitoring is, of course, going to be a lot more accurate. It is going to detect electrical signals from the baby's heart as well as true uterine pressure during the contractions. But it is invasive, unfortunately. So it's really only going to be used when needed, right? If it's really necessary, we're going to use it. And the baby needs to be reachable through the cervix. So the cervix already has to be dilated and the membranes need to be ruptured. So again, not anybody can get the internal monitoring. Now it's going to be gold for you to know on the NCLEX when internal monitoring is indicated, right? And that's going to be when external monitoring can't track baby because of either external fatty tissue, because of fetal distress, or because of twins. And again, this is likely going to be already a high risk labor. And it's going to require cervical dilation and rupture of the membranes, right? The water being broken. Now, what are fetal heart tones, right? Fetal heart tones refer to the heartbeat of the fetus, which is going to be assessed usually throughout the pregnancy if they're getting regular prenatal care. And it's also going to be monitored during labor to determine the well being of the fetus. A normal fetal heart rate range is going to be between 110 to 160 beats per minute, but that can change with the gestational age. But usually during labor, we're expecting this range. And this baseline rate is going to be assessed usually between the contractions, right? Because during contractions, the baby's vital signs are going to change. And then, of course, it's going to be in the absence of accelerations and decelerations as well. Now, the baseline of is the average fetal heart rate of over 10 minutes. excluding accelerations and decelerations, and we really want it to stay around 110 to 160. And if there are any periodic changes in the fetal heart rate, like accelerations or decelerations, let me tell you a little bit about them. So accelerations temporarily increase the fetal heart rate by 15 beats per minute for about 15 seconds if the baby's over 32 weeks. And it is associated with fetal movement. And it's actually a reassuring sign. Usually it means baby is well oxygenated. And then decelerations are going to be important to understand. You need to understand the type of deceleration that's happening. This is going to be crucial knowledge on the NCLEX. And I want you to use the veal chop mnemonic to remember the causes. You've probably already heard veal chop in your nursing school or in any of your studies that you may have done. So if you have tachycardia, this usually can mean infection or stress for the baby. And bradycardia is actually worse because it may mean that there's cord compression that's being prolonged or that there's uteroplacental insufficiency, right? The uterus just is not able to work hard enough to push baby out. So for the NCLEX, I want you to match the cause with the fetal heart rate change and know what the priority intervention is. So we know that it's going to be monitored using an ultrasound transducer, right, for fetal heart rate. And then for the contractions, they're going to be using a toco transducer. Again, external is going to be non-invasive, internal is going to be for high risk, and it's going to give you a lot better numbers. And it is going to require ruptured membranes and cervical dilation, right? Now remember here for the NCLEX, again, just some little tips to remember. Moderate variability is good, right? Moderate variability plus accelerations means the fetus is healthy. Now, if you have absent variability and late decelerations, that means the fetus may have some hypoxia, and this is going to be a huge priority. Make sure that you're assessing variability and identifying decelerations before choosing what intervention you're going to use, right? So if you're seeing that on the NCLEX, know how to combine with each one. And if you are seeing any non-reassuring fetal heart rate patterns, make sure that you do use this sequence that I'm about to tell you. It's going to be turn mom on the left side, administer oxygen, stop Pitocin if it's running or oxytocin, give IV fluids, and notify the healthcare provider. I'm going to say it again. So if you are seeing any non-reassuring fetal heart rate patterns, I want you to turn mom on her left side first, positioning first. I want you to administer oxygen, stop Pitocin or oxytocin if it's being administered, give IV fluids, and notify the healthcare provider in that order. Now let's talk a little bit about fetal heart rate variability. This is going to be referring to the fluctuations in the baseline fetal heart rate that are irregular, and the irregularity is going to be referring to amplitude and frequency. And the fetal heart rate variability is going to reflect neurologic regulation of the fetal heart as well as autonomic regulation of the fetal heart. Basically, it's telling us how responsive the baby is, right? So good variability is going to equal healthy oxygenation and a healthy nervous system. And variability is also going to show how the brain and the autonomic nervous system are working, right? It's going to be how much the heart rate is wiggling from the baseline. Basically, that's what variability means. Now, if you don't have any variability whatsoever, if it's absent, that's not a good thing. This is suggesting that we have possible hypoxia or something is happening with the brain. And if we have moderate variability, this is the best thing that we want to see. It means that our baby is oxygenated and their central nervous system is healthy and doing well. So we're going to watch for variability changes after decelerations, or so if we're seeing decelerations or we're giving medications like narcotics to mom, we're going to be watching the variability. And the NCLEX may ask you to evaluate the variability to decide the fetal well-being. So I have a little chart here for you. If you have absent variability, it's just kind of flat, not really showing much. That's not a good thing, right? We talked about that. Absent variability is going to be baby is possibly hypoxic or there's some process going on in the brain. If you have minimal variability, which is going to be less than 5 beats per minute, variability is still not that great. We want it to be moderate though, right? We want it to be 6 to 25 beats per minute. This is a good sign of oxygenation. That's going to be the best one. And then marked variability is going to be above 25 beats per minute. Now I want to talk to you about the mnemonic VEAL CHOP that we mentioned earlier. VEAL CHOP stands for variable chord, early head, acceleration okay, and late placenta. So if you are having, and I have a little chart here for you, if you are having early decelerations, the cause for that is head compression, which is normal. And that means that your decelerations are matching the contractions, right? They're mirroring the contractions. So I had a chart here for you. So early decel, you're seeing the fetal heart rate and the contraction, they're mirroring each other. This means head compression, which is a good thing. This is fine. It means the baby's head is being squeezed as it's passing through the vaginal canal, right? So this is going to be expected, and you don't really need any intervention for that. Now, if you have variable deceleration, there may be compression of the cord happening here, and variable deceleration is going to look like this. It's going to be kind of an abrupt VU shape. This can happen anytime, and this is very bad. We are going to reposition mom. That's going to be our first intervention for variable accelerations. And that means, again, there could be compression of the cord. And if the cord is being compressed, what does that mean, right? We're compressing the only way that the fetus is getting blood flow and oxygen. So we definitely need to reposition mom quickly here. And then if we have late decelerations, this is going to mean placental insufficiency. And that's usually going to happen after a contraction. And the intervention here is going to be the poise mnemonic. So execute poise. So just remember, early means the baby's head is being squeezed, it's fine. Variable is a cord issue, you need to act really fast for this one. And late means the placenta is failing and you need to give oxygen and reposition mom. And poise is what I was talking to you guys about earlier. It's that order I want you to remember. It's position, which is going to be left lateral, give oxygen, IV fluids, stop oxytocin, and evaluate. Now I have some more charts for you here. Again, download the slides so you can review this later on your own time. And this has your nursing actions here, your descriptions, and what the cause is on the NCLEX. You really gonna want to study this. And then we have variability patterns here for you. Now, let me go ahead and ask you some questions here. What's the normal fetal heart rate baseline? And that's going to be 110 to 160. What fetal heart variability is going to be ideal? And that's going to be moderate, which is between 6 to 25 beats per minute. What decelerations are going to mirror the contraction? And that's going to be early decels, which is head compression. And if you guys remember, that means baby's fine. Baby's head is being squeezed as it's passing through the canal. And what's going to be your first action for variable decelerations? And that's going to be reposition mom, right? Left lateral. And what does poise stand for? That's going to stand for position, oxygen, IV fluids, stop oxytocin, and evaluate fetal and maternal status in that order. Now I have one more small section. I'm going to try to get through it quickly here for you guys so we can go over our questions together. And this is going to be about the 4 stages of labor. We're going to talk about stage 1 today, and then on our next webinar next week, we're going to talk about stages 2, 3, and 4. So let's talk about stage 1. This is going to be the longest stage of labor. This is going to be where the cervix is softening, thinning, opening up from 0 to 10 centimeters. It's going to be divided into 3 stages: the latent phase, the active phase, and transition phase. And I'll talk about each of those for you as well. And each of these phases are going to look different, right, for the laboring person. As a nurse, your interventions are going to change with each phase, from comfort and education in the latent phase to pain relief and lots of emotional support in the active phase to close monitoring and reassurance in transition. That's going to be the toughest one out of all of them. We're going to go ahead and break them all down here for you. So the latent phase is going to be early labor. This is going to last usually hours to days, right? This person can be in the latent phase dilating between 0 to 5 centimeter for a while, especially if it's a first-time parent. And the contractions here are going to be pretty mild. They're going to be irregular. They're going to be spaced out. Moms are usually going to be upbeat, social, talking about, oh my God, I'm in labor. I'm so excited. Calling up everybody, call grandma, call auntie, call bestie. And your role here is going to be teach the mom, hydrate the mom, and reassure the mom. You're going to encourage lots of movement, walking around, changing positions, and you're also going to encourage relaxation, right? Like take a nap. This is the time for you to take a nap because things are going to get a lot more difficult later. And of course, you're going to keep your tone nice, calm, and supportive. And of course, during this time, you're going to monitor vitals and fetal heart rate usually every 30 to 60 minutes if mom is not already on continuous monitoring. In the active phase is when labor is going to get real. Contractions are going to get a lot longer. They're going to get a lot stronger and closer together. So they're going to be about every 3 to 5 minutes and they're going to last about a minute each. And moms are usually going to lose their social energy at this time and they're going to kind of turn inward and get a lot more serious, right? This is the time that you're going to usually provide pain relief, non pharmacologic or pharmacologic. You're going to help them with positioning and helping them to progress the labor. They're going to be usually around 6 to 7 centimeters at this point. You're going to offer an epidural if they want. If not, okay. And you're going to kind of coach them through their contractions along with their support person. And you're going to keep your communication really simple and supportive. They're not going to be able to pay attention to a lot of talking during this point because they're going to be focusing on working through their pain. You're also going to continue to monitor their cervix and their fetal heart rate around every 15 minutes to 30 minutes. And you're going to go ahead and encourage them to void. We want them to keep an empty bladder so it doesn't interfere with the progress of labor. On phase 3, which is the transition phase, this is known to be the most difficult phase during labor. It's really intense, but it's usually short and it's very powerful. Usually moms may cry, they may vomit, they may feel super nauseous, they may shake completely, and they may feel really out of control at this point. And that's totally normal. Their hormones are going to be peaking at this point. Their body is almost ready to push baby out. So your job is going to be literally just be their rock. You're going to give really clear, confident guidance, and you're not going to let them push until they're 10 centimeters. Even if they feel the urge to push before then, they have to wait. Now, you can offer cold cloths for the sweating. You can offer breathing cues, and you can offer lots of reassurance. This is when they're going to need you the most. So stay calm, stay present, give them firm coaching. You're going to prepare them for delivery. You're going to notify the physician. Of course, you're going to be letting the physician know, updates during their labor. They're going to feel a lot of pressure this time, and you're going to be monitoring the fetal heart rate every 15 minutes. So I have a little chart here for you to kind of know what each of the 3 phases are. And like I said, download the PowerPoint and go through these. It's going to be very important for you to know for the NCLEX. And I want to go ahead and give you some Q&As real quick here before we jump into our questions. The dilation range of active labor is going to be 6 to 7 centimeters. What phase is going to show irritability, nausea, and rectal pressure? And that's going to be the transition phase between 8 to 10. And what's the top priority before allowing the client to push? They have to be complete. They have to be fully dilated at 10 centimeters. And what should the nurse do during the latent phase? This is going to be a time to educate mom, hydrate mom, and encourage lots of movement to help with progression of labor. And why is it important to void during active labor? And that's going to be because a full bladder is going to block fetal descent and it's also going to increase pain in the uterus. So we want to go ahead and encourage moms to void. Now let's go ahead and work on our questions. We have just enough time here to go through our 10 questions. Sorry, I talked a little bit fast towards the end there. This was a pretty comprehensive webinar covering lots of topics. So let's go ahead and work on our first question here. I would love it if somebody could unmute and read for me. If you're too shy, I will read it myself, but I will give it a minute here. See if anybody wants to participate.
A nurse is assessing a client who is 34-week gestational and diagnosed with placenta previa. Which of the following should a nurse prioritize? Monitor for signs of infection, access for vaginal bleeding, encourage bed rest, provide emotional support for the client. I'll go with 2
Yep.
because placenta previa, that is painless bleeding with a little drop of blood.
Yep, absolutely. You are correct. It is 2. Placenta previa is where we have that painless, bright red bleeding. It's when the placenta is covering the cervix in some way, right? Partially or entirely. By the way, thank you so much for reading that for us and sharing your answer. And this is a really significant cause of hemorrhage, right? So if the patient's coming in with symptoms or diagnosed placenta previa, we want to make sure that they're not bleeding. This is going to be a hallmark symptom. So it's really important for us to know if they're bleeding, because this is going to indicate how severe the condition is. And also, is there compromise to mom and baby? And we're going to monitor that bleeding to know what interventions we need. Now, the reasons why we didn't choose the other answers, right? Monitor for signs of infection, definitely a concern, but it's not going to be the primary concern with placenta previa. And the reason why is because our focus is going to be on managing the bleeding and preventing complications. And then option 3 here was encourage bed rest. And the reason why we're not encouraging bed rest is because this is going to be a part of the management, but again, not the primary thing that we want to do. It's not the immediate priority. We need to assess for bleeding first. And then, of course, option 4 was provide emotional support. This is always going to be important. However, our assessment for the bleeding is going to come before emotional support. So after we assess bleeding, we're going to go ahead and support the patient emotionally. But first, we need to see what's going on to guide our interventions. Who wants to read question 2?
A nurse is caring for a client who is 36 weeks gestation and experiencing a ruptured placenta. Which of the following should the nurse prioritize? So I'm going to read it again. A nurse is caring for a client who is 36 weeks gestation and experiencing a ruptured placenta. Which of the following should the nurse prioritize? 1. Administer oxygen. 2. Prepare for emergency cesarean delivery. 3. Monitor maternal vital signs frequently. 4. Ensure availability of blood products for transfusion. I would go with I'll go with 2.
Yep,
Prepare for emergency cesarean section delivery, because the patient is at risk for is a complicated situation. Patients are at risk for bleeding.
yep,
Yeah, so we need to bring the baby out immediately.
yep.
Yeah, so
Absolutely. You're absolutely correct. Thank you for sharing that with us. Thank you for sharing your critical thinking and also for reading the question with us. And it's true, prepare for emergency cesarean delivery is going to be the primary intervention in this case. Again, this client is 36 weeks gestation. The baby is pretty much ready to come. And abruptio placenta is going to be putting both mom and baby at a much higher risk. So we are going to go ahead and prepare them for a cesarean delivery. And this is going to address the compromise of what's going on, right? We're going to deliver rapidly to prevent any complications, any hemorrhaging, any prolonged, hypoxia of the baby. And the reasons why we didn't choose the other options here, administer oxygen therapy. Again, this is going to be supportive, right? But it's not going to it's not going to change the outcome. It's not going to fix what's happening. It's not going to put the placenta back together, right? We need to go ahead and deliver baby immediately in order to stabilize both mom and baby. Option 3 is obvious, monitor maternal vital signs frequently. We're going to do this anyways. But this is again going to be secondary to the cause of the distress of mom and baby, which is the hemorrhaging. And then, of course, option 4, ensuring that blood products are available. Again, this is going to be an important part of our nursing care anyways, but it's not going to be the immediate priority. We know that intervening immediately that in a way that's going to save both mom and baby's life is going to look like delivering baby right away. So good job on that one. All right, we have question 3 here. Who wants to read this one?
A nurse is performing the Leopold maneuvers on a client in labor. Which of the following findings should the nurse prioritize? Presentation of the fetus, position of the fetus, engagement of the fetal head, attitude of the fetus. So I can go with the 2, the position.
I love that. Okay. And thank you so much for reading that for us too. So this one's kind of tricky, right? Because Leopold's maneuver is going to be assessing a few different things. But here we're talking about the priority finding, right? And the priority finding is going to be the most effective one that's going to guide our interventions, right? And that's actually going to be um, the presentation of the fetus. And the reason why is because that's going to influence how the delivery is going to go. Now, immediately looking at that, you would think it's the position, right? But the presentation is what's going to guide us if there are any complications during labor, and we need to anticipate what our interventions are going to be. So we are going to go ahead and prioritize fetal presentation. Now, the reason why it's not position is because, again, this is important, but it's secondary because the presentation is going to have a lot more immediate impact. Now, the presentation is talking about what's the presenting part, right? Is it going to be the head? Is it going to be the feet? Is it going to be an arm? Is it going to be a cord? Those are going to be really scary presentations there. We really just want it to be the head, right? And if it's the feet, if the baby's breech, we're most likely going to go for a cesarean, although vaginal deliveries have been successful in breech before. That is definitely not the preferred method for physicians. So we are going to look for fetal presentation as the priority here. Now, option 3, the engagement of the fetal head. This is definitely going to be assessment, or I'm sorry, it's going to be relevant in the assessment because we want to know, is the baby engaged, right? But again, it's not going to be more important than knowing what is the presenting part. The presenting part is going to guide how we can anticipate if there are any complications and how we're going to intervene in those complications. And then, of course, the attitude of the fetus is going to be helpful in the evaluation too, but it's not going to be more important than the presentation. So, presentation, again, we want it to be cephalic, which is when the head is pointing down. We don't want it to be breech, transverse, and we definitely don't want a cord presenting first. Thank you so much for participating with us. Anybody want to read question 4? And if not, I can chime in and read it here. A nurse is reviewing a fetal heart rate tracing that's obtained through external monitoring. Which of the following indicates an abnormal pattern? So we have a baseline fetal heart rate of 140 beats per minute. Let's think if that one is within the range. Accelerations present with movement, persistent late decelerations, or moderate variability in fetal heart rate. Now, this is a question that's asking us about what is a normal finding versus an abnormal finding here. So let me see what you guys are saying in the chat box. What you're telling me is the answer here. I'm getting lots of 3s for this one. And you guys are absolutely correct. Good job applying your knowledge here. And it's going to be persistent decelerations. And the reason why is because a persistent late decel is going to indicate uteroplacental insufficiency, right? It means the placenta is just not, the uterus and the placenta are not working hard enough. And there's going to be hypoxia of the baby. So this is going to require us to intervene right away in order to prevent any negative outcomes for baby. Now, the reason why the other ones were incorrect is because a fetal heart rate of 140 beats per minute is totally within the normal range, right? We know it's between 110 and 160. And we also know that accelerations with movement are actually reassuring. That means baby's okay. It's a normal central nervous system response. So we're happy about that. And then moderate variability is going to be the optimal variability, right? Between 6 and 25 beats per minute. This means our baby is oxygenated and they have a healthy nervous system. And if anybody wants to read question 5, if not, I will read it.
A nurse is assisting a client in active phase of stage 1 labor. Which of the following interventions is most appropriate? Encourage frequent position changes, promote hydration through IV fluids, provide emotional support during contractions, monitor fetal heart rate every 15 minutes. So I would go with answer number 2, to promote hydration through IV fluids. Yeah.
Thank you so much for reading that for us. I appreciate you. And actually, that's a good discussion here, right? To see which one is the most appropriate intervention here. So let's think about the active phase of stage 1 labor. The active phase is going to be that phase where mom starts to become, things start to get more serious. Mom starts to get, a lot more pain. And at this point, we're really assessing for the fetal heart rate. We're assessing for, do we have decelerations going on? Is there any cord compression? How is baby handling labor, right? Because now contractions are getting longer. And every time the contractions are getting longer, that's more time the baby is without proper oxygenation. So the most important intervention here is actually going to be to monitor the fetal heart rate every 15 minutes. And I'm going to tell you why. Again, we need to detect if there is any fetal distress going on. Labor is not a fun process for baby or for mom, right? It is a necessary process, but it's definitely stressful for both. Baby's going to be stressed out when the head is being compressed, when the placenta is being compressed by the uterus, contracting. So we're going to go ahead and check on baby and make sure that there's no the stress going on. We're going to make sure baby's safe throughout labor. And at this point, we are going to be monitoring every 15 minutes, usually 15 to 30 minutes, but 15 to be safe, right? And since the question was asking about the intervention that's most appropriate, we're looking for the intervention that's going to prevent harm to both mom and baby. Now, the reason why we didn't choose option 1, frequent position changes, this is going to be secondary to fetal monitoring. This is usually going to be more in the earlier phase of labor, which is the latent phase. We're going to be encouraging position changes to help with labor progression, right? But it's not going to be priority over monitoring baby. And then option 2, IV hydration, that was a really good option. I definitely would have chosen that one too. And that's because IV hydration is going to be so important for mom and baby. Most moms in labor are usually receiving IV hydration. But again, when you compare IV hydration to monitoring the baby's heart rate, the IV hydration is not necessarily assuring us that baby is safe and baby is okay and baby is handling the labor well, right? All the compressions from the contractions. So we are going to go ahead and monitor baby. That's going to be priority over IV hydration. But that's not to say that IV hydration doesn't have its own benefits, right? That's going to actually be a part of our poise mnemonic. If we do have the stress, we are going to give mom fluids. Now, option 3, emotional support. Again, emotional support never comes before physiological interventions. So it is going to be important, but we are going to monitor the baby. That's going to be a lot more important than emotional support at this point because it's going to address complications directly and it's going to address the baby's safety directly. Anybody want to read question 6?
A nurse is caring for a client in the transition phase of labor. Which of the following findings should the nurse monitor for closely? Increased fetal movement, rapid cervical dilation, decreased intensity of contractions, um, maternal complaints of hunger. Which of the following findings should the nurse monitor for closely? I would go with number 2 because it's a sign that the patient is about to deliver. So we need to make
Yes,
that the patient
absolutely.
is comfortable. The mom is comfortable to deliver safely.
Absolutely. You're absolutely right. And that's going to indicate too, like when mom is ready to push, right? When is mom complete? So good job on that one. Thank you so much for reading and sharing your thinking with us. And yeah, absolutely. Mom is in the transition phase. This is the last phase before delivery, right? Mom is going to be between 8 to 10 centimeters. Things are going to get really tough at this point. It's going to be short. It's going to be powerful. And now we're talking about which finding we need to monitor really closely, right? And that's definitely going to be rapid cervical dilation. This is going to be letting us know where they are in this transition phase. And we need to prepare for delivery, right? We need to let the physician know. Usually they might be in the room by this point, depending on what the delivery and the history of the mom is like. But typically, yeah, we definitely want to know when delivery is imminent. We need to let the physician know so that they're present. Sometimes they're not. Sometimes the nurse ends up delivering baby, and that's fine too. But yeah, that's going to be the most important one. Now, the reason why we didn't choose increased fetal movement is going to be because that's not really a finding of the transition phase, right? Right now, we're really concerned about how close we are to delivery. Is mom complete? Is mom at 10 centimeters? Are we able to push? Usually, fetal movements are going to decrease during this time because the baby is descending, and the contractions are so hard that we can't really be detecting a lot of movement. Option 3, decreased intensity of contractions. Definitely incorrect, right? If they're in transition, their contractions are going to be a lot stronger. They're going to be a lot closer together because baby is so close to coming out and cervical dilation is so intense at this point. And then option 4, maternal complaints of hunger, really uncommon at this point. Mom is definitely not going to be hungry. She's most likely going to be really nauseous, really like anxious, really fearful. She might be saying, I can't do this, I can't do this. She's definitely not going to be focusing on eating. She might even have like vomiting during the space. So definitely no hunger at this point. She'll be hungry after, though, I promise you, after using all that energy. All right, I'll have somebody read 7 for me.
A nurse is assessing a client with appropriate placenta, which of the following findings is indicative of this condition? Right leg vagina bleeding, painless vagina bleeding, bleeding firm, painful internal contraction,
I will go with
decrease
one.
further outbreak variability. That would be the right leg vagina bleeding.
So what do you guys think? I heard 1. Are we divided on this
There's
one?
1, there's 3. I know it's not painless. Painless is
Because
the
the
other one.
placenta, that is the bright red vagina
Red
bleed.
vagina. Yeah, that should be placenta.
Abruption placenta is the dark red, not
It's
bright
supposed to be
red.
dark red,
It's
not
3.
bright red. That's what I'm saying. To be 3. Because the stomach will be distended, right?
I love this discussion that you guys are having. I
There
did
will be
hear
distension and there
No,
will be pain.
the stomach, the abdomen
Distension
will
and
be
pain.
firm. The
Yes.
abdomen will be firm, and there will be pain for you to end
Pain.
contraction.
Yes.
Yep, absolutely. You're correct. And I love that you guys are having this discussion because it's true. Like, we remember there's vaginal bleeding in abruptio placenta, right? There's always going to be, well, not always. Sometimes it's going to be concealed in there, but we are going to have vaginal bleeding. But again, because of where the bleeding is coming from, remember with placenta previa, because it's covering the cervix, the bleeding is going to be bright red and it's going to be painless. But with abruptio placenta, the bleeding is going to be coming closer from kind of deeper in the uterus. So it's actually going to be dark red by the time it comes out. So option 1 was a distractor here. So we are going to be with option 3, firm, painful uterine contractions. Now, of course, contractions are going to be painful anyways. However, the uterus is going to be really tender, really painful, and it's going to be really firm and rigid to the touch, right? So option 3 is the correct answer here. And this is letting us know that there is separation of the placenta and potential distress, right, to the baby. So definitely bright red bleeding is going to be characteristic of placenta previa. Painless bleeding is also going to be placenta previa, and decreased fetal heart rate variability may happen with this, but it's not going to be the first finding. It's going to be a secondary finding. The uterus being really tight and really painful is going to be the primary finding besides the dark red blood. So that was a really good discussion that you guys had. And I could hear that all of you guys had your rationales for it, but it's definitely going to be option 3. Great job. I love hearing you guys applying your knowledge here. And then we have question A, if anybody wants to read this one. And if not, I can go ahead and jump in here. A nurse is planning care for a client with multiple gestations. So let's start thinking, remember what we learned about multiples. Which of the following interventions should be prioritized? So let's remember what our risk factors and complications are, right? And we're going to have a select all that apply here. So we're going to choose more than one answer. So we have provide education on dietary modifications. And again, we're looking for priority here, right? So maybe most of the answers could be correct, but we're thinking about priority that's going to indicate how do we keep mom and baby safe? So option 2 is going to be monitor for signs of preterm labor. Option 3 is going to be assess for preeclampsia. Option 4 is going to be encourage use of support garments. And option 5 is going to be restrict physical activity entirely. That sounds a little bit excessive, right? So what do you guys think? I'm seeing in the chat here 2, 3, and 4. Let's see.
2, 3.
Yep, absolutely.
Only 2, 3 depend the question on 2
Yeah,
3.
2 and 3, you're absolutely right. And the reason why here is going to be why 2, right? Because preterm labor is a huge risk factor and complication. Having multiples is a risk factor for preterm labor, and preterm labor is a common complication of having a multiple gestation. So we're going to go ahead and monitor for signs, and we're also going to educate the patient about it, right? So we're going to go ahead and make sure that we are monitoring for that, because depending on how early they deliver, that could indicate, that fetus is going to need, or that baby is going to need a lot of support after they come out. And then option 3 is going to be assessing preeclampsia. Why is that? Because we know that moms with multiple gestation are at really high risk for preeclampsia. There's a heightened risk for moms with multiple gestation. So we're going to go ahead and detect this situation early on so that we can manage it appropriately. Now, the reasons why education on dietary modifications weren't priority, again, beneficial. They're going to need extra nutrients, but not the priority, right? And then, of course, support garments are going to provide comfort, but again, they're not going to take precedence over preterm labor and preeclampsia, which both can have devastating effects on mom and baby. And then restricting physical activity entirely, again, definitely not recommended unless they're having serious complications that put them at bed rest. And then I'll go ahead and read question 9 for you guys here. And this one is, a nurse is observing periodic patterns in fetal heart rate. Which findings are considered abnormal? Select all that apply. So we're just identifying here what's normal versus abnormal. Is it going to be late decels, variable decels, early decels, tachycardia above 160, or moderate variability? What do you guys think?
1, 2, and 4.
Love it. You're absolutely right. 1, 2, and 4. And I see some some of our participants being divided here in the chat box, but you're right, it is 1, 2, and 4. And that means that you really are applying your knowledge in identifying what's normal and what's not normal here with this mom. And this tells me that you're going to be able to identify early, you recognize these findings that are dangerous for mom and baby. And we know that late decels are definitely abnormal because they're letting us know that there's uteroplacental insufficiency and the baby is becoming hypoxic. This is going to require really, really fast intervention. We're going to use that poise mnemonic. We're going to reposition mom. We're going to give oxygen therapy. And then also option 2, variable decels. These are also going to be considered abnormal, especially if they're repetitive, severe, or prolonged. And these are going to come from umbilical cord compression. Again, this is going to be fast intervention, right? We're going to go ahead and make sure that we are getting oxygen to that baby. And then tachycardia above 160 is going to be abnormal, especially if it's happening over 10 minutes. This is going to be scary because it could mean that baby has an infection, that they have, low oxygen, or there could be some other factors affecting baby because of mom. So those are definitely going to be our red flag symptoms there. And early decels are going to be normal. They mean that baby's head is being compressed as it's descending, and they're actually okay, and they mean baby is fine. There's no distress going on there. And then moderate variability is ideal. This is a normal finding. This is what we want. It means baby's oxygenated well, and it means their nervous system is working well. And I'll read question 10 here for you. A nurse is performing Leopold's maneuvers. Which of the following techniques are correct? Select all that apply. Determine fetal lie, assess fetal position, palpate uterine tone, locate fetal back, or evaluate maternal pulse. This is going to be a little bit of recall here from what Leopold's maneuver was. 1, 2, and 4.
1, 2,
That's
and
1, 2, 4.
4.
Yep. Good job. I love that. You guys are remembering correctly here. So it's definitely 1, 2, and 4. Determining the fetal lie is going to be a one step of Leopold's maneuver. This is going to help us to see the orientation of the baby within the uterus. Option 2 is going to be assessing the position. This is going to help us to understand the relationship of the presenting part, which could be, the head, the feet, the limbs, to maternal landmarks like where their spine, the pelvis of the mom is. And this is going to help us to understand how to manage labor according to the position. And then locating the fetal back is going to help us to understand where baby is going to help us to place fetal monitors so that we can monitor baby's heart rate. And it's going to help us to get accurate fetal heart rates, right? Because we need that in order to understand the baby's well-being in the belly, especially during labor. Now, option 3 was incorrect, palpating uterine tone. This is not a part of Leopold's maneuvers. And then option 5, evaluating maternal pulse. Again, completely unrelated to Leopold's maneuver. This is going to be more about assessing where baby is and how baby's position is in the belly. So since we are over our time here, I'm just going to give you a quick little conclusion here. I want you to know, remember the differences between placenta previa and abruptio placenta, which are both OB emergencies. I want you to remember your torch infections and what risks come from each one and how to prevent them. I want you to support and monitor multiple gestations closely and remember what the risk factors and complications are. And I want you to remember the 4 P's of labor so you can effectively assess mom and baby. And master fetal heart rate patterns. Use your veal chop mnemonic here. And remember, take a look at those charts that I provided in the PowerPoint. Those are going to be really powerful to help you remember. Remember to prioritize safety through each stage of labor and how each stage correlates with how you're going to prioritize safety for mom and baby, right? And then you're going to recognize signs of complications early on so you can intervene and make sure mom and baby are safe. And of course, as always, we're going to do patient-centered care. We're going to provide lots of education, empathy, and empower our patients. And you guys actually did a great job, as always, applying critical thinking, prioritizing your ABCs, and using your Maslow's hierarchy wisely. I didn't really go over our test taking strategies today, but I always do on all the webinars that I do. Today we were a little bit short on time, but if you download the PowerPoint, you will see those slides in there. And I want you to always remember, what do I see? What does that mean? And what do I do about it, right? That's what nursing is all about. So I want to thank you for being here today. I want to thank you guys that participated and answered questions and read questions with me. I also want to thank you guys that didn't participate too. Thank you for paying attention and listening. Thank you for showing up today and for being a part of our NCLEX community. I'm going to share a little link with you guys here. If you feel like it, you can go ahead and drop your feedback. Let us know how the session went for you. Was it helpful? Did you like it? Did you not like it? How did I do presenting the information? And I want you guys to have an amazing weekend and an amazing night. And thank you to all of you that were sleepy, that are across the world, that are in different time zones, and you're tired, but you stuck it through and you listened to all this information. And you guys are definitely going to be better for it when you head over to take the NCLEX. You're going to be confident and you're going to remember all this information that you learned.
Thank you so much.
Thank you.
Thank you guys.
When
It
are
was
you
such
having
a
your next
pleasure.
class?
Thank you for asking. I am doing a class
Thank
on the
you.
15th, so in 3 days on the 15th, and that's going to be 4 p.m. On Pacific time. On Eastern time, that's going to be 7 p.m., and that one's going to be continuing labor and birth. So we're going to talk more about labor and birth during that presentation.
I'll be taking my NCLEX on the 16th.
Could you kindly share the
Oh,
recordings? I
oh
came
my
a bit
goodness.
late.
Oh yeah, let me share a screenshot. I'm gonna drop a screenshot here in the chat box for you guys so you can see where you can
And
find
when is the
the
video going to be
recording.
available to watch?
They should be uploaded over the weekend.
Oh, okay.
Yeah, you guys should be able to see it in there over the weekend. But I'm gonna give you the screenshot here. Let me see if I can find it. I'll drop it in the chat box here for you guys. But yeah, so it should be when you go into your NCLEX, there is a section called previous webinars. That's going to be on your left taskbar. And you're going to go ahead and click on that. And that's going to take you to our previously recorded webinars. And it's also going to contain our PowerPoints to each webinar that you can go ahead and download alongside so you can follow along and you can study and review all the bullet points and such. And if any of you are taking your NCLEX this week, I heard someone say they're taking it on the 16th. Good luck. You've got
Yeah.
this. Remember
Thank
your,
you.
yes, you're welcome. You're going to do amazing. Remember your prioritization strategies. That's going to be the most important thing.
Mm-hmm. Thank you.
Yeah, you're welcome. Thank you guys so much for being here. I'm
I
going to
have
let
a
you guys.
question.
Go ahead.
It's just a suggestion. Can we have the previous webinars grouped according to system by system? If
Okay.
you check the way it is scattered, you have to like look for it. But I feel if it's grouped system by system, it makes it easy to search.
That's a great suggestion. I don't have control over that, so I'm definitely going to put that out. I'm going to talk to the IT team and let them know that you guys had that suggestion and see if they can get that put together for you. That sounds great. I love that idea. Organizing is always nice. If in the time being, for you to find something easier, you can do Control Find on your computer or Control F and then just type in like the title and it should take you to it and like highlight it just as like a temporary fix. But I will definitely present that idea to them and see if they can put that together for you guys. Thank you for that.
Thank you so much and have a good evening.
Thank you so much, you too, you guys. You have a wonderful evening and a wonderful rest of your weekend. And
You
Thank
too.
you.
Thank
Good
you.
night.
Good
bye.
night.
Have a
Good
good
night.
night.
Appreciate it. Thank you.
Thank you as well. Bye.